All right, so the October Mech Minute is going to be a review of the new American Heart Association update on basic life support and advanced life support. We're going to talk this month about adults. This is going to be basically a quick review of what the American Heart Association released on October 21st. So what we're going to talk about is we're going to talk about the adult side of BLS and ALS guidelines as they were released on the 21st. I'm going to talk some about those things that were new, and there are some new guidelines added, which seem to be for the first time, which have to do with guidelines for termination and resuscitation, guidelines for the management of a pregnant female who's in cardiac arrest, and then cardiac arrest secondary to opioids. So I'll speak about these guidelines. There have also been some minor changes here and there, as well as some additional items inserted that we will consider for the 2021 protocol. So probably going to make a few changes. Some changes we may consider for implementation at another date. There are some things that we already do that are well in tuned, if not ahead of the game, as published in the new guidelines. And then I'm also going to talk about some changes or recommendations in the guidelines that you should consider implementing as part of your work practice. There are things that may or may not be in the guidelines or in our protocol, but I think there are good things for you to consider as part of your work process as an EMS provider. Next month, Dr. Stoner will talk about the pediatric and neonatal updates as issued by the American Heart Association on the 21st. So really, before I get too far into this, the American Heart Association likes to talk about class of recommendations, meaning the strength of documentation, support research that supports their recommendations. So green is good. Green means that these are class 1 recommendations. There's great benefit to the patient, and there is indication that these recommendation, or this particular recommendation that's rated green, is good for the patient, and it should be the standard of practice. So that's what you'll see as part of this when I go through here, but there are also other levels of support or strength of the recommendation all the way to the bottom, which is a red bar. It's a class 3, which means actually things that are considered or have been found to be harmful. Really what we're going to see in the recommendations, the updates go maybe down to a 2B, which is weak, or a 3, but the 3 with a harm, that's not going to be anything that we typically talk about today. And there's also various level of evidence that's used to support the recommendations. Sometimes there's good research. There are randomly controlled trials of a particular subject that shows positive effectiveness, positive benefit, and good outcome to the patient. But there are some recommendations that are going to have where they're going to be a class 1 or class 2, but the level of evidence is not going to be very high. So it's going to be more, well, we think based upon clinical practice, based on our research, based on combining data from multiple studies and coming out with evidence of support. That's called meta-analysis. If we combine all these studies together, it seems like this procedure, this drug, whatever, seems to benefit the patient. And then the lowest level is where there's expert opinion, which basically say the experts in cardiac resuscitation say we should do this, or it's something we should do, but there's really not great research to support it. It's basically what our experience tells us we should do. So if we move forward, we talk about the chain of survival. I think we've all seen it. If you talk about the chain as it is, they've added extra links. So for those patients who suffer cardiac arrest in the hospital, the in-hospital cardiac arrest chain of survival, they've added recovery. If you look at the pre-hospital phase, they've added recovery as well. So recovery, what do we do to help patients recover from their cardiac arrest, has become an important component of the chain of survival now. For BLS for healthcare providers, not a whole lot of new news here. So this is the algorithm that I've got that is for adult cardiac arrest. I have it for both BLS and ALS, so you'll see the same algorithm on the next slide. But for BLS, basic life support, there's really not any big changes. They still recommend quick CPR. They recognize bystander CPR. There's still talk about early defibrillation, whether it's bystander provided or EMS provided or provided by the healthcare providers at the hospital. So from my perspective, there's probably not a lot of big changes for BLS coming through the 2021 guideline update. If we look at the same algorithm from the perspective of ALS providers and adult cardiac arrest, excuse me, shockable rhythm is still the big thing, early CPR. If you have electricity, you give it as soon as you can, as soon as you identify VFib, VTAC. If you look at it, it really talks about defibrillation coming before CPR. I think we'll have to see what the final guidelines come out as part of the ALS class. I think if the patient has a prolonged downtime, and it's not a witnessed cardiac arrest, meaning you did not witness the patient go into arrest, then I would still do CPR for 2 minutes before we shock the patient. So I don't anticipate any changes in our CPR algorithm where we would shock the patient as soon as we get in the room versus our current practice of getting on the floor, doing compressions for 2 minutes before we shock the patient. I think we're going to continue to do CPR for those patients that are in a shockable rhythm before you shock. For those rhythms that are not shockable, so PEA and asystole, there's been an emphasis on early administration. So epinephrine has been questioned in terms of its efficacy. Does it really work? There are a lot of studies that suggest that it does not have any effect in terms of survival to discharge from the hospital. It does seem to have an effect in terms of survival to arrival at the hospital. But the American Heart Association now says that if we're going to give epinephrine for an asystolic or PEA arrest, we have to give it soon. We have to do it as soon as we can get in there, and they even show it as being something we give at about the time or before we start CPR. I would go for you get that CPR started, you get your intravascular access obtained, and then you give the epi. If you look at the content that's in the current update, they suggest that we try for a peripheral IV before we go for a tibial IV because studies have shown that outcomes from resuscitation where we use a tibial IO the outcomes are not as good as if we give intravenous medications. Last year we went to giving humeral meds. So in a cardiac arrest, we went from using the tibia to the humerus, the humeral head as the preferred point of access for intraosseous needles. My preference is going to continue that. You know, when we go into a cardiac arrest, we place a humeral IO unless you have very quick and easy access to a vein. But I suspect that we're going to continue to see the humeral IO as our preferred method of access because we have rapid movement of medication from the syringe into the circulation. It's close to the heart. Studies suggest that it's as good as a central line. So I think that we are going to continue to use the humeral IO as the preferred initial point of vascular access for patients in cardiac arrest. So you walk in and on an asystolic or PEA arrest, you start your CPR, you get vascular access through a humeral IO, and you give epinephrine as soon as you can administer it. And then you stick to the 3 to 5 minute schedule of epinephrine administration. They talk about the adult cardiac arrest circular algorithm. This is basically what we do already. We do CPR, we give medications, we shock the patient, we reassess the patient for recovery and so on. This algorithm or this circular algorithm that they have, it calls for rhythm check. We are going to continue to use capnography as our preferred means of assessing for ROSC. We are going to continue to avoid any delays for pulse checks unless we have reason to think there's ROSC based upon a increase in capnography. So I do not anticipate any changes into our process. I do not see us starting to do pulse checks again as part of our every 2 minute swap out of manpower. We want to keep those compressions going, and if we can get an airway in, whether it's a supraglottic or endotracheal tube, and we see a change in capnography, then we will stop and check for a blood pressure and or pulse rate, or a pulse, palpable pulse. Just a quick mention about wide complex tachycardia. This is something we looked at last year. We originally had in our algorithms you could try IV adenosine as your first step in treating a patient with wide complex tachycardia. We found that we had a lot of patients where in wide complex tachycardia it really was VTAC and not a SVT or a tachycardia, sinus tachycardia with widened QRS. So these were truly VTAC patients. Adenosine didn't work. We ended up then going to either cardioversion or amiodarone. We have since taken the adenosine out as a first-line treatment for patients in wide complex tachycardia. If they're in wide complex tachycardia, they're either stable or unstable. If they're stable, they get amiodarone. If they're unstable, they get cardioversion. I think if you look at patients, if you look at amiodarone, it's really for us as EMS providers a good drug in managing tachycardias. If you have a patient with atrial fibrillation, if you have a patient with VTAC, if you have a patient with any of those other arrhythmias, then it's really a safer drug. It's a better drug, I think. So we're not going to put adenosine back in the algorithm. We're going to continue to use amiodarone. And if you look at their level of evidence for recommendations of both these are not great. And they're I think this is a good way for us to continue to doing things. We'll continue to use the amiodarone. And if the patient's unstable, we'll sedate and cardiovert. There's some talk about airway. The American Heart Association recognizes that there are airway options now. They see the supraglottic device, which for us is the iGel, to be pretty much an equivalent to an endotracheal tube. And really in the outpatient setting, they indicate the decision on whether or not you use a supraglottic device or iGel versus intubating the patient. Really that decision should be based on the operator experience. So if you are an EMS provider and you routinely place endotracheal tubes, you've had years of experience and you're very good with endotracheal tube placement, then we would advocate that you go for an endotracheal tube to secure the airway. We will do that without interrupting CPR. If you are a paramedic with limited experience in doing intubations and you have had not a stellar success rate in getting a tube into the trachea, then in a circumstance of a cardiac arrest, our focus should be on placing the iGel. This is one of those items that I mentioned where you should examine your clinical practice. It is okay to say, let's just get a iGel in, we have an airway secured, we can get capnography started, and we can move on to other priorities during the resuscitation. If you have adequate manpower to take care of your treatment priorities and you are an experienced operator, a laryngoscope or a King Vision, go ahead and place the endotracheal tube, but keep in mind, we do not stop compressions in order for you to get that airway in. And if you have trouble getting the tube in, just abort the procedure, ventilate the patient a little bit, and then place the iGel. So this is an opportunity if you would examine your own clinical experience and your own clinical practice. You have tools to follow either of these paths. Post-arrest management. So this is a new one in some ways. It talks about a couple things that I've highlighted with the red box. The first has to do with setting goals for your end-tidal CO2 and your pulse oximetry. So we really want to keep our SpO2 between 92 and 98%. We don't need to have the patient running at 100% oxygen unless they need it. So look at that and keep in mind that we really want to maintain an optimal PCO2 of between 35 and 45. We do not want to hyperventilate the patient and blow off all the carbon dioxide. This is where we come down to that: how vigorously do you squeeze the bag and how often do you do it? So our goal should be we squeeze the bag enough to ventilate the patient. We talk about pinching the bag rather than trying to use the entire volume of the bag. And we ventilate the patient every 6 seconds, which is about 10 times a minute. So those are parameters you can establish and follow once the patient has recovered from their cardiac arrest and now you're stabilizing and preparing for transport. So put end-tidal CO2 on if you don't already have it, put the patient on pulse oximetry, and look for those goals of O2 saturation of 92 to 98% and a PCO2 on your capnography of between 35 and 45. The other thing I want to emphasize, and we've talked about this before, it's on the list to be added to the protocol. It's just that American Heart got to it first, is if you have a patient who is successfully resuscitated in the field and you have ROSC, part of your routine should be to obtain a 12-lead electrocardiogram. So let the dust settle, kind of get in your groove, and once you're able, get a 12-lead electrocardiogram. We're going to add this to the protocol. So one of the expected steps of a patient who has ROSC is to get a 12-lead ECG and to send it to the receiving hospital. So we do that because if the patient has any evidence of STEMI post-arrest, they typically go to the cath lab unless there's some reason for them not to go, identified by the cardiologist. So that pre-arrival electrocardiogram that shows a STEMI is important because regardless of where you're going, if the receiving hospital knows they're getting a STEMI patient, your 12-lead can give the hospital 5, 10, 15, 20 minutes of prep time to prepare to get that patient to the cath lab. So this is another part where part of your work habits should be, if you have a patient with ROSC, that you should get a 12-lead electrocardiogram. The last thing, there's continued focus on temperature management, and that is really something that is a hospital objective now. We do not worry about targeted temperature management in the field. We don't do the 2 liters of cold saline anymore, but there is still a continued emphasis on patients with ROSC, once they arrive at the receiving facility, get cooled. If there are contraindications, such as the patient is unstable and so on, but we should expect our receiving hospitals to cool the patient at some point shortly after arrival. This is just a breakdown of some of those recommendations. Again, we want to avoid hyperoxygenating the patient, and we also want to avoid patients becoming hypoxic. So we're going to target our O2 levels. We're also going to target our CO2 levels. And these are all expectations of the American Heart Association, and I think this is very well spelled out for everybody. There is an increased focus in the guidelines about prognostication. In other words, if this patient's had a cardiac arrest, when do we start thinking about outcome? When do we start thinking about is this patient having or suffering from anoxic brain injury, and maybe at some point care will be terminated, they'll be moved into palliative care or hospice. This is not something that we are going to do in the field, but it is really something that we may start looking at in the future in terms of determining destinations. So, generally the expectation is that a patient is not determined brain dead for at least 72 hours after their arrest, because they need to be stabilized, they need to go on targeted temperature management, they need to be cooled, they need to be maintained at that cooler temperature for 24 hours, then they need to be rewarmed. So if somebody's going to prognosticate 24 hours into their hospital stay following a cardiac arrest, that may be a facility at some point we may start challenging and say, do you really want us to keep bringing you patients because you don't seem to have much of an interest in their long-term recovery. So we'll look at that. I just wanted to bring this up because it's on there, and I know it's been an issue for some in the past. Just some special subjects. These are some of the new areas in the publication. Anaphylaxis is published. I think this is the first time I have seen it. As we've talked about on previous Beck Minutes, it's all about epinephrine. So any patient with acute allergic reaction should be getting epinephrine. If you look at the top 4 items there with the red bracket, I put it on the right. They're all level 1 recommendations. We think that patients should receive intramuscular epi through an autoinjector, or you can draw up 1 to 1,000 and give 0.2 to 0.5 based on their weight. If their patient is at least a bit shocky, you need to monitor their hemodynamic status. And if the patient's showing evidence of oropharyngeal or tongue edema, laryngeal edema, wheezing, you need to get them to see a emergency department physician as soon as possible. And you need to think about how you're going to maintain and manage their airway during transport. You can use IV epinephrine if the patient is shocky, and you can also use IV infusion. in patients who are shocky and require pressor support. We have epinephrine as our pressor of choice in the protocol. So a lot of what's on here is nothing new, but it's just a re-emphasis that the treatment for anaphylaxis is epinephrine. Everything else is secondary. Opioid overdose, this is the first time they really talk about it. I was kind of disappointed in it. This is the algorithm. So they have a version for healthcare. They have an algorithm for non-healthcare providers, which is basically the public. I didn't bother to put this in the discussion. But really, to me, there's not much of a change. They recommend checking 10 seconds to see if there's a pulse or not before starting CPR. They talk about using AED. They say consider using naloxone. To me, that there's really no guidance on Narcan. I don't see Narcan as really having much benefit of effect. Everything else should come first. But really, there are no studies that show improvement in outcome with Narcan. So I don't understand why American Heart did not make just a statement that says Narcan has no indication in use for cardiac arrest secondary to an opioid. A little disappointing for me, but I thought I would show this to you. Cardiac arrest in pregnancy, this was a new one. Basically a female, a mother with child who's in cardiac arrest, if she's far enough along in pregnancy, may be a candidate for immediate perimortem cesarean section. This is one of those circumstances where you follow the algorithm, you treat mom in cardiac arrest really no different than you do if she was not pregnant, but your scene time should be minimal. Your scene time should be long enough to start compression, shock if necessary, but get her packaged, get her in the truck, and get her to the closest obstetrical hospital fast, because if there's any chance of baby survival, it may be because the obstetrician does a perimortem cesarean section. This is not an EMS procedure, but you have to realize that a pregnant female in cardiac arrest may be a candidate for a cesarean section in the emergency department. Not done very often because we don't have many women in cardiac arrest, but sometimes it happens. There's also an increased focus on pushing the pregnant uterus to the patient's left. You do this because it takes the pregnant uterus and its weight off of the vena cava, which improves venous return to the heart, so you have blood to circulate when you compress. So part of your treatment plan for a pregnant female in cardiac arrest is to move the uterus to the left with gentle pressure if it's big enough to move. If we're talking about somebody who's in their first trimester, it's probably not an issue, but anybody at 20 weeks or more, for sure, there's an opportunity to move the uterus off to the patient's left. Termination of resuscitation, they have two standards out there. This is based on research that's been out there for a number of years. They have a set of criteria for BLS termination or ACLS termination, and it really has to do with whether or not the arrest is witnessed by EMS versus by bystanders, and whether or not there's bystander CPR. Those are the big difference between ACLS and BLS. But essentially, for BLS providers, if their arrest was not witnessed by EMS, there was no spontaneous return of circulation, and there's no AED use, then you can terminate in the field. For ACLS providers, if the arrest was not witnessed by anybody, and there was no bystander CPR, there was no spontaneous return of circulation, and no shock was delivered, then you can terminate as well. So this seems simpler than our current protocol. It doesn't have any discussion regarding trauma, hypothermia, and so on. We'll take a look at it in regards to our protocol, maybe make a change, maybe not. More to come on that. But Chief Weber and I will have that conversation soon to determine if we're going to make any significant changes to our termination and resuscitation protocol. Drowning, new to the guidelines as well. Early CPR is important, so as soon as you can start compressors, do it. If you have to provide any effort or any form of resuscitation, that patient gets transported. So that's the second level 1 recommendation. I got the red bar around it, the red box around it. So any victims of drowning who require any form of resuscitation should be transported to the hospital for evaluation and monitoring. And then they really say that routine stabilization of the cervical spine in the absence of any mechanism of injury is not recommended. So if the patient was swimming and then drowned, they don't need a C-spine support. If they dove into the pool, hit their head and drowned, they need cervical spine immobilization. Overdose management, this is kind of new. I just threw this in there. They cover a couple different items. I just thought you'd find this interesting. These are recommendations that are best useful as a 2A, so the benefits exceed the risk, but typically the level of evidence is low in terms of the treatment modalities that are offered, and that's because we don't see a lot of these. But I throw this up there because if you call poison control and identify one of these toxicities, they may advise you to use medications that you have on your truck. So the first is beta blockers, so Inderal, metoprolol, any of those beta blockers. If the patient is in shock, IV glucagon is a reasonable treatment. You have it on the truck. And you may need to give the patient more than you have on the truck. Typically in the emergency department, when we have a beta blocker overdose, we give them between 3 and 5 milligrams of glucagon. You might have 1 or 2. So that's something to keep in mind. You also may consider giving calcium to the patient, but in terms of these overdoses, I would not give either of these drugs unless you talk to poison control first. Another one would be calcium channel blockers like verapamil, ditilazem, other drugs like that. They're calcium channel blockers. So if the patient's suffering from an overdose and they're symptomatic and they're shocky, we have calcium chloride in our trucks to treat hyperkalemia. Again, calcium is an option. And then, excuse me, glucagon is also another option for calcium channel blockers. For tricyclic overdoses, Elavil, any of those other drugs that are tricyclics, sodium bicarb is a drug of choice for patients in cardiac arrest, or if they have a wide QRS. So if you have a young patient who took a bunch of amitriptyline tablets, and now they are tachycardic with a wide complex and maybe a little shocky, the treatment would be IV fluids and IV bicarb. Again, I would check with with poison control to verify that this treatment's appropriate, but you do have drugs on the car in your truck that can help patients with these overdoses. And finally, cocaine. Cocaine patients who are severely intoxicated with cocaine, the treatment of choice is benzos. You have Versed on the truck, so if the patient's just ingested a bunch of cocaine, now they're tachycardic and hypertensive, you could administer benzodiazepines, whether it's intranasal, intramuscular, or IV. So just keep that in mind in your back pocket. So this is the first time I've really seen in the AHI guidelines this level of detail regarding treatment of specific types of overdoses. Just some odds and ends, and then I'll be done. Some other issues they discussed that I just kind of summarized here. Double sequential defibrillation, they make basically a statement that says usefulness has not been established. I know I've been pretty obvious in my opinion that if patient's not responding to standard defibrillation and amiodarone, my preference would be that we change pad position to anterior-posterior and try that way. From my last review, there have been no big studies that show the double sequential defibrillation works. Vascular access, for patients in cardiac arrest, they suggest attempting an IV. I would have a low threshold to go from an IV attempt to a humeral IO. It all depends on the type of veins you see. If you see these big pipes in the forum, you want to make a go for it, do it. But if you're talking about our typical patient we have in cardiac arrest, I would probably not worry about getting an IV. I would just go to the humeral IO. Epinephrine continues to be recommended for cardiac arrest. Routine use of calcium and sodium bicarbonate not recommended. I still think bicarb has a bit of a role in patients who are in prolonged arrest. We do have an indication in our protocol for calcium and bicarb for patients who are on dialysis and have a cardiac arrest. We use these drugs because the patient may be hyperkalemic from their renal failure. So we do have protocol items that call for calcium and sodium bicarb. I don't see those changing, but more to come. End-tidal CO2 can be used to detect ROSC during compressions. We have been doing that. We will continue to do that. We will continue to use end-tidal CO2 as our preferred means of determining ROSC, and we will not stop compressions to do pulse checks unless we see the end-tidal go up. They make a statement that mechanical CPR may be considered in specific circumstances but not recommended for routine use. I think this is largely because there are no studies that show mechanical CPR is superior to manual CPR. We've known about that all along. It's just a matter of when we're looking at how we can staff our trucks and resources that may be available. We use mechanical CPR to transport patients because that way our providers can be secured and seat belted into a seat during emergent transport. Nobody's hanging over the patient to do compressions. We have a machine doing it. And the last one I've put in there has to do with the impedance threshold device, or the ITD. Has no benefit proven for cardiac arrest and is not recommended. We took the ITDs out of our vehicles a while ago. I know that a certain representative out there from one of the supply companies, one of the vendors, is recommending that we put ITDs back on our trucks as part of a package for cardiac resuscitation. I think really it's the training that goes with that package and not the ITD that makes benefit. We're not going to recommend putting ITD back in our trucks at this point in time. That's it for me. That puts us at about 30 minutes, which is my promise of 20 slides in 30 minutes. Looks like I kept my promise this month. Next month will be the pediatric and neonatal version. Again, call or email if you have any questions.